Good morning, everyone. So I'll be discussing with you how to manage choroidal detachments, and so choroidal detachment, as we all know, is a separation of choroid from sclera by accumulation of fluid, blood, or air. So it happens when a potential space is converted into a true space. So there could be a serious type of choroidal detachment where the low IOP promotes transitation of fluid out from choroidal vasculature. Could happen in post-surgical hypotony, post-traumatic, or secondary to inflammation. You can have a hemorrhagic choroidal detachment due to rupture of choroidal vessels, which can happen spontaneously or during surgery or during trauma. Or you can have an uveal effusion syndrome, which can be associated with choroidal detachments. So this is a various differential diagnosis. Various causes which leads to choroidal detachments. This includes scleropathies, the inflammatory causes, the hydrodynamic causes, and the neoplastic causes. So how to differentiate between a serous and a hemorrhagic choroidal detachment? I think the B-scan ultrasound is the best tool. In B-scan, in serous choroidal detachment, you'll have a smooth dome-shaped elevations which are free from the optic nerve. They are not attached to the optic nerve. So and there are no after movements and very low internal reflectivity. So this internal reflectivity is the thing which differentiates the serous choroidal detachment from hemorrhagic choroidal detachments, which appear like this. So again, smooth dome-shaped, free optic nerve, no after movements, and high internal reflectivity. So I think a B-scan becomes important when you have a choroidal patient with choroidal detachment coming, to differentiate between a serous and a hemorrhagic choroidal detachment. So how to manage serous choroidal detachments? Most commonly is a conservative approach, because most of them often spontaneously they come down. You can give oral as well as topical corticosteroids and topical cycloplegics. If there are any wound leaks, you can apply a pressure patching or a bandage contact lens or glue. Basically, you have to build up the pressure. And if the patient is in ciliary shock post-surgical, you have to give oral fluids just to relieve the ciliary shock. Then if nothing of this is working, you go ahead with the surgical approach, in which is if it is a non-resolving or recurrent choroidal detachments, or you are having a persistently flat AC, which may lead to synechiae formation, or you have a kissing choroidals which may not heal spontaneously, and intraoperative during VR surgery, if you find there is choroidal detachment, you have to manage them intraoperatively. And similarly for hemorrhagic choroidal detachments, again, the conservative approach includes the antibiotics, corticosteroids, cycloplegics, anti-glaucoma drugs, and oral fluids. And in surgical, again, it's an uncontrolled glaucoma. If it is an uncontrolled glaucoma, if there are kissing choroidals, or if there's a persistent vitreous hemorrhage or retinal detachment, you go ahead with the surgery. So now I'll show some videos on how to manage this. So first thing is, when you are operating, you're doing a vitreous surgery, you have to be sure that your cannula is in the vitreous cavities. The video is not playing. No, the first one was not playing. No. So this is what is called an endoilluminator reflex test. I think it gets stuck over here. Yeah. So you just what you do is you just take your endolite and you insert it in inside the cannula which you have just placed, and you will get this reddish brown reflex instead of a very good white reflex. So this is so you know that there is choroidals and your cannula is not in the true vitreous cavity. And you see, this is the white reflex you should get if your cannula is inside the vitreous cavity. So you can compare it again. You see that this is the reddish brown reflex, and this is the white reflex you generally get. So this again, the third sclerotomy is made, and you again see that you are getting a white reflex. So your cannula is in the space. So don't use the cannula which you have made for infusion. You put your infusion in one of the other cannulas, and you start your vitrectomy. And now you confirm whether your cannula was in the right space or not. And you see your cannula was not in the right space. It was covered with choroid. So you just cut back the choroid, and once the cannula comes into the vitreous cavity, just clear off the vitreous and other tissue which is over there, so that the cannula stays in place. And now you see the reflex again. It is a white reflex. So this is an important test which you can do to evaluate whether your cannula is inside. So this is how you use a 26 gauge needle to manage intraoperative this choroidal detachments. So once you are completed with the vitrectomy, you see there is a choroidal detachment superiorly, and now you just take a 26 gauge needle and just go into the suprachoroidal space. The fluid starts draining because there is an infusion, and with the passive outcome of this suprachoroidal fluid, now you see the choroidals have settled. So you can use a simple 26 gauge needle to drain this space. Now this is a video which was given to me by Dr. Manisha, and what she has used is the use of a non-valved cannula to drain out this suprachoroidal fluid. So you see this fluid comes through this suprachoroidal, and you can manipulate the cannula to have a proper drainage outside. So now you see the choroid which was detached has now, the fluid has gone, and it's relatively attached. So I generally use a technique what I call a controlled cannula drainage. I use a 26 gauge IV catheter to drain most of my suprachoroidal or subretinal fluid which is present. Okay, the video again got stuck. I don't have in this with them. Yeah. Yeah. So this is the ordinary 26 gauge IV catheter. Yeah. So this was how it works is, you see this is a patient with a bullous retinal detachment, and there was hardly any space to do a vitrectomy in this patient. So I just take this IV catheter, and a point of the greatest elevation I just insert it. So this is I'm explaining it how to drain the subretinal fluid. Same way you can drain a suprachoroidal fluid. So once you see the tip is inside the subretinal space, you just advance the plastic tubing and withdraw the metallic stellate. And once you do that, you can see that the fluid is coming out of this. And now you can connect this cannula to your extrusion pump, and you can actively control the rate of drainage of the fluid from the subretinal or suprachoroidal space. So you can do it faster if you have to drain a lot of fluid, and you can drain it slower if the space becomes shallow. So this technique has got several surgical advantages. And this was a 56 years female, status post-scleral buckling, and he had a recurrent RD with massive choroidals. And so to drain this, we again, because there was a buckle inside there, so it was very difficult to open it and just go inside. And so we used this cannula to reach this area. You see the tip of the cannula now in the suprachoroidal space. And once you see this, you can start draining it, and you see the level of the choroidal detachment slowly coming down. And this blunt tip need not be withdrawn on decrease in fluid, because it is blunt, it is not going to injure your choroid. And you can do it at multiple sites because it's transconjunctival. So you can do a drainage at multiple sites, and you can reach quite posteriorly. You can see the tip of this cannula reaching up to the macula also. So if the pocket is quite posterior, you can drain that also. And you can leave the cannula while you are doing other procedures, like you're doing laser, or so you can just leave the cannula there and let the fluid drain out while you are doing other procedures. So this was another patient with a post-traumatic choroidal detachment and hemorrhage, and You again see there was so less space that you cannot operate. And again, I use this technique. With a fast mode, I just drain the choroidals very quickly. So this was a patient of kissing choroidals, and the one thing that you have to keep in mind is, because there's no space to insert your instruments, you have to make a anterior chamber. You have to place an anterior chamber maintainer, so that when you start draining, it does not result in hypotony and resultant hyphema or a vitreous hemorrhage. Again, I'm using this same technique to drain out the choroidal fluid. So this is, I think I have time. So this is a patient of, this is just to show hemorrhagic choroidal detachment being managed. So this was a patient with a post-cataract surgery choroidal detachment, suprachoroidal hemorrhage and vitreous hemorrhage, and retinal detachment. So again, I'm using the controlled cannula drainage technique to drain out this suprachoroidal hemorrhage. And once you have settled the choroid, you proceed ahead with your vitrectomy. You make a retinotomy because there was so massive subretinal hemorrhage. I plan to have a large retinotomy in this case, but start with the smaller one and drain as much of subretinal hemorrhage through that smaller retinotomy. Because if you make a larger one and try to drain, the blood will come into the vitreous cavity and obscure your vision. So make a small retinotomy and remove the subretinal blood. And then you can increase your retinotomy, and then now this patient is converted into a giant retinal tear, and you can manage it accordingly. So this is again nano-ophthalmos. You have to do partial thickness sclerotomies to manage choroidal detachment or retinal detachment, which has happened secondary to nano-ophthalmos. And this, sorry. So this is the way you do it, as we used to do earlier when we used to do implants, scleral implants for retinal detachment. You make these partial thickness flaps, and then you excise those flaps. You can do it in all the quadrants, depending upon how much you want to. I prefer to, once I start doing it, I prefer to do this sclerotomy in all the quadrants. Sclerectomy. So this sclera is removed, and these patients generally, they have very thick sclera, so it's important to remove as much of the tissue as you can. So complete in all the quadrants. And then this is 3 months post-operative. The retina has settled and the choroidals have settled. And you can compare the pre-operative and the post-operative picture, and the patient's vision improved to 6/18. And now this is my last video. Again, this patient, you can't drain from outside. This is, again, I borrowed from Dr. Manisha. You can make this choroidotomy from internally, and then you can drain the fluid from this choroidotomy that you have made, and you can settle the retina from internally, and then you laser this choroidotomy, and you can get a good result. Thank you.
Thank you, Dr. Sangeet, for those interesting videos. I think, Dr. Oni, you have any question? Yeah, please.
Or any trick to prevent that, and to know if you have to move
if it is the retina is interiorly placed?
Because of the choroidals, the anterior retina is also interiorly
yes.
And a lot of times we create break at the entry.
Break at the end.
It's easily managed, but if we can, any tips to avoid that?
I think if you know that the retina is very, or the choroidals are very bullous and the retina is coming up, you can always drain the choroidals first before making a final entry into the vitreous cavity. I think that will help. I think Dr. Mahesh.
Yeah, I would probably reattach the choroidal detachment before we go inside. So my technique is slightly different. You can use the trocar cannula system, but just go inside up to the broadest part of the trocar goes inside and twist it so that it keeps the sclerotomy open, and then inject with the other hand into the antechamber or into the vitreous cavity. That itself will allow the serous choroidal detachment to come out through the sclerotomy site. And once the fluid stops coming, then I go inside completely. And any doubtful case, I would probably use a 6mm cannula. You can use a 6mm cannula in a phakic patient also, provided we keep it in our mind that we are using a 6mm cannula. And doesn't mean that all the time it will touch the lens. We can manage that way.
Yeah. So the idea is to drain the choroidals first, let the thing settle down, and then enter the.
Dr. Sangeet, in one of your videos, we saw that you've used a 27 gauge system. Any problems you face when you are dealing with an RDCD with a 27 gauge?
Not really, as such, nothing as such. The only problem is that these are valved cannulas. So if you want to drain it through these cannulas, it